Welcome to the, August 2025 PD Parlor with Dr. Priya Cardone. She's a movement disorder specialist neurologist from UPMC. And Dr. Cardone, really appreciate your time. And we'll be hearing about some new therapies. Looking forward to it. Dr. Cardone, take it away.
Okay. Hi everybody. Good afternoon. I hope everyone's having a good summer. So I thought this time would be a good time to talk about two new treatment options that are just different. They entered the market within the past 1 year, one right after the other. Kind of old concepts, but new representation and like a new idea that came forward. So love to always have as many treatment options available for our patients so that we can have everybody be as close to their baseline as possible and have as good a quality of life as possible. So, can you, sorry, how do I share my screen again? Oh yeah, share. Okay, are you able to see my screen now?
Yes, it's like a screen in a screen.
Okay, can you see my slides now?
Yes, maybe just,
Is that good?
yes.
Okay.
And if you don't mind, your volume's a little lower.
Oh, okay, sorry.
You don't mind, because we don't want to miss
I'll
anything.
just shout louder. How about that?
Okay,
If there's anything.
great.
Yeah, I'll just talk loud. Okay, so today we're going to be talking about the two subcutaneous pumps that are now on the market and available for treatment of Parkinson's disease symptoms. All right, so first of all, there are different ways to get medications into the body. Obvious one is taking oral medications that goes in the stomach, goes through the gut, and then you can get it absorbed through the gut. So that's one. That's the obvious, most easy, most common way. Separate from that, however, there are ways to get medicine in the body there's one medication that's an inhaler that inhales like a powder form of a material into the lungs, and that goes into the bloodstream by the lungs. And then the other option is using the skin. The skin is actually the largest organ in the body. So it is a good route of being able to get medications into the body. So using the skin to treat Parkinson's disease symptoms with medication is not a new concept. So many of you have heard of or are using or have used something called the Nupro patch. That's the most common brand name. The generic version of that is rotigotine. Basically, it's a dopamine agonist. So if you recall from earlier lectures, one of the problems in Parkinson's disease is the cause is that there is a lack of dopamine producing cells in the brain. So you make less dopamine, so you have less activation of these dopamine receptors. And dopamine is the chemical that helps you move, including gut motility and body motility and other internal organs, a little bit of them as well. So, one method of treating Parkinson's disease is to give you the ingredients to make dopamine. But another way of treating Parkinson's disease symptoms is to simply activate these receptors using something that looks like or acts like, mimics dopamine. So the dopamine agonist patch, the rotigotine patch, comes in 2, 4, 6, or 8 milligrams daily. You stick it on different body parts. People can get some good symptom control with that. So building off of this basic idea, concept, that's how the rest of these medications were likely developed. So there are 4 ways of getting medication in or through skin, I guess I'll say. So Duopa is the first one. I've probably talked about this in the past. It's sort of, I think it's kind of been replaced by its more easy to use and less invasive counterpart, which is Vyalev, but it is still available. And then Vyalev is one of the subcutaneous dopamine infusion pumps. Apomorphine is an older injectable medication, and that is the same exact chemical medication that's in this new pump, which is called Onapgo. So I'll go through all of those one at a time. So Duopa, if you guys recall, if you've seen any of my earlier lectures, that's a pump that goes through the skin and it delivers medication actually into the intestines. So it's not really using the skin, it's just going through the skin, but I had to talk about this before I talk about like the newer version of this. So this was a pump that had to be surgically inserted into the intestine, and it comes with a little, kind of like the handheld cartridge device that has vials of liquid dopamine gel, and that gel infuses through this pump and directly into the stomach. And patients would wear that all day. You adjust the rate up or down, and it works. It would have worked pretty well. It did work pretty well. I've had a couple patients who have had it through the years, but the drawback here is nobody nobody wanted jumps at the idea of having a invasive tube put into their gut. It's invasive. There's a risk of infection. You have to find a surgeon to put it in, and you have to constantly monitor to make sure there's no like any other secondary complications. So second to this, by I believe same company, is Vyalev. So Vyalev is phos-carbidopa, phos-levodopa. It's again liquid dopamine, like a gel, kind of a subcutaneous infusion, meaning it goes in under the skin. This is a 24-hour pump. When you get it kind of installed in the doctor's office. Get it onto your skin, get it going, and then all the dosages are adjusted in the office visit. It provides options for different rates that you can cycle through during the daytime versus nighttime, and you can also give yourself extra doses as needed. So here is a picture of the cartridge or the little machine, like the actual pump part. So this is what the patient would hold in their hands. So you can see there's like just a couple buttons, not too complicated here. A button to start, it shows you like the battery level of the pump, what is the rate that you're getting, and options to go up or down once you click into the different settings. These are the materials that the patient would actually have available to them. The syringe that contains the dopamine and the gel that goes inside this cartridge. This part is what connects the cartridge to the patient's skin. And I have another picture that'll show you kind of what does the end product look like. This is what it ends up looking like. So here's the pump part. Here's the little wire, and it goes right onto the skin. So this is you have to like press this into your skin. There's a teeny tiny needle in there. It's about like, I don't know, like a quarter of an inch or smaller than that. Goes right under the skin and infuses that dopamine gel into the subcutaneous tissues. So, and patients can either get like a little belt, or some people wear a vest and they put that pump part into the vest. Here's another little picture of how it looks. So a little tube, pretty thin here, and then this applicator portion is also quite small, probably the size of like a quarter, a little bit bigger, and it just sticks right onto the skin. So here's what it might look like for somebody with their clothes on. So it's not very obtrusive. You almost may not even notice. It looks like it could just be like a fanny pack or a purse. This person's got it on under her clothing. So depending on your style and what is your daily activities, that's how non-invasive and non-obtrusive it could look. Okay, so what are the perks of Vyalev? So, and what is the purpose of this? So all of the infusion medications are to help with people who are taking oral medications but are having either it not having enough effect, having to take so much medication that they're getting more side effect than actual medication benefit, having ups and downs, because recall, if you take oral medications, that depends on gut motility and absorption. So if a patient ever complains about having wearing off or fluctuation of symptoms, you have to always back that up with one extra question, which is, are you having constipation? Meaning, are you having less than one bowel movement every other day? If you are having more than 2 days without a bowel movement, that means you have to get the gut moving better so that the medications can get absorbed better and you can have better effect. So these two, well, all of these treatment options basically bypass the stomach. So the first one, the Duopa, goes into the intestine after the stomach, but again, also still depends on gut motility. But the two subcutaneous pumps do not depend on gut motility. So that's one way to bypass this issue. One of them, oh yeah, Vyalev offers treatment throughout the entire night because it's a 24-hour treatment option. Potential side effects, which we've seen, unfortunately, a little bit of a kind of a site reaction or cellulitis, to the point of needing to have some antibiotics. So that's what we're kind of trying to figure out a workaround for that. And then the adjustments do have to be made in the office. I'll ask Shelly to comment a little bit more, but for the patients who I've had the cellulitis, I've asked them to start using this salicylic acid body wash, especially on the stomach area, before inserting each of the invasive parts. And I don't know if that's going to work or not, but that's the only idea I had. So I guess I'll be able to give you guys an update on that in maybe like a year or two to see if the patients who had that cellulitis no longer had it after they started using a little bit of a salicylic acid body wash, which basically just exfoliates a little bit of that top layer of skin, cleans the skin, and maybe may reduce some of the chances of irritation. That's my guess, though. I don't have any data on it. Okay, then the other way of treating Parkinson's disease symptoms. So recall, the Vyalev is dopamine, basically. That is dopamine replacing the dopamine that your brain is not making. The other way of treating Parkinson's disease symptoms is you give something that goes and sits on the dopamine receptors and acts and looks and pretends to be dopamine. So that option there is a medication called Apomorphine, which is the generic. This is a chemical that stimulates dopamine receptors in the brain, and it works on two different types of receptors. One of these is activating, and one of these is actually like a balancer. So like one goes up, one goes down, but by activating them both, it kind of brings them both into balance to be able to have good, better symptom control. So apomorphine is not a new idea. There are several versions of this. The first one to talk about is Apokin, which exists still. Apokin is a rescue medication for patients who are having off phenomenon. It's an injection, so if you're in a sudden frozen state, you're off, you would give yourself one of these injections and it should kick you back into your on state within like 10 or 15 minutes. So this is considered a rescue medication. The side effects, however, is like it can make people feel a little bit sick, like flushed, and they can have some vomiting, so they don't always feel so good after this. But that's also hard to judge because when you're in your off state, you also don't really feel good. So it's not like, you're feeling perfectly fine and you took this and you feel miserable. It's like you were in a rough state, you were in your off state, you use this, now you can move, but maybe still don't also feel good. So that's one option as a rescue medication. So this is not something you would use repeatedly over the course of the day, like multiple times. It's to be used as sparingly as possible for off periods. And if a patient is having such frequent off periods that they need to use this more than once per day, then again, you need to go back and revisit or back it up one step and say, why are you having such bad off periods? Are you not taking medicine correctly? Is it not getting absorbed? Is it not enough? And so see if you can correct like the original part of the problem or the cause of the problem rather than having to rely on injection rescue medications too often. Okay, so the newer version now of apomorphine, instead of the injection, is a pump. So the pump, again, infuses subcutaneous apomorphine under the skin. It's 16 hours. So this is the one where you would take a break from it at night for about 8 hours. So the purpose of this medication is to reduce off time, and it has to be used as an adjunct. So the patient has to be on some type of oral medication already, and then this can be used as a booster or an adjunct, but not as a single therapy for all of the symptoms. One of the perks here is that all the installation and the adjustments can be made at the patient's home by one of their nurse navigators. So that's one of the perks there. In terms of side effects, I don't have any patients yet. I have a bunch of people who are like in the pipeline, but I don't think I have anybody off the top of my head. I don't have anybody who's definitely already started to be able to know if there's any like regular or common side effects. So again, something that I'll have to give you guys an update on maybe in a year or so. All right, and here's some pictures of the Onapgo device. This is the pump portion, the medication, the tubing, and the part that goes in. So if you can see here, there's a tiny needle here. And I actually have guest appearances by both of the reps today, so hopefully they'll be able to show you a little more detail with the actual device a little closer to the camera. Okay, so this is like one of the brochure kind of pamphlet descriptions of how to use this. So you get everything ready, you insert a vial into the syringe, you connect that syringe to this pump, You use the applicator to stick it into the skin subcutaneously, and then you just press go and it would start. Sorry, so again, that's kind of the scale of how it looks compared to being on a body. All right, here's another picture. So this is kind of the size of the pump, and this is the part that goes into the skin. And this is kind of like the carry case that you can have to take everything with you or keep everything together. So not too bulky on this one either. Okay, so those are kind of the intros about both of those. So if I have either of the reps, I can give the screen to them. I think Shelly is gonna go first. Casey, do you know how I share the screen with one person, or make one person a co-host?
I'm not. I see. Let's see here. I think I need to remove the spotlight. Okay. And now, Shelly, you can go ahead. Let me spotlight you.
Thanks, Shelly. Thank you for making time in your day to help us and show us some of the equipment, and so patients can be a little more familiar with this treatment option.
Sure, no problem. Thank you actually for having me and asking me to do this. A couple things that I wanted to show you. You were talking about the cannula and the cannula size. So this is the actual cannula. And the cannula itself is about the size between a quarter and a 50-cent piece, if that helps you. And then the actual little piece of plastic that goes into your skin is right here. So you can see it's very minute. There's no needle there. If people are familiar with an insulin pump, this is kind of the same thing that people with an insulin pump use. So even kids with type 1 diabetes would use something similar to that. And then basically the line clicks into here like this. And then it hooks up to the pump itself. And inside the pump, it has a little reservoir, and that's what holds the medication. And then it screws on to here like this. And this is actually to kind of give you a size comparison. So this is a cell phone, and it's the same exact size as an iPhone Max. So, and it actually weighs less than an iPhone Max because this is less than a pound. So even though it might look bigger or it might look kind of scary, it's not, because you can fit it in a pocket. I have gentlemen that put it in different pockets or different type of cargo pockets. I have people that put it in their back pocket. I have people that wear it in crossbodies. I have people that use our vest. There's different ways that they hold it. So it's actually pretty nice and convenient for patients. And a lot of the patients say that they like it because they don't have to worry about protein content with taking this, because like Dr. Cardone said, it bypasses the stomach. So you don't have to worry about what you're eating or the timing of eating or anything like that. And basically you just set it in the morning and you can forget it throughout the day unless you need an extra dose or you need to change the settings, because you have the options to change it between 3 different settings. So it really does personalize to you and to your lifestyle and what your individual needs are. And we can dose it within 1.7 milligrams of levodopa carbidopa. So that really does give people the ability to make it fit into what their individual needs are.
Shelly, can you tell people a little bit about how often they need to change the cannula, because that's a common question, and then insurance is also a common question. Is this covered by insurance?
Yeah, so the cannulas are recommended to be changed out every 3 days. Most of the patients do change it out more often than that, just because of convenience and the way that they have to change out the medicine. It's easier for them. And then as far as insurance are covered, so right now it's covered for everybody. There is no age requirement now. And then it is being covered by all insurances now. But I will tell you that if you have a Medicare Advantage plan, those ones tend to take longer to get the approval for those. And anytime that you're dealing with anything with Medicare, if you can't afford the copays, please, please, please ask and or tell them, I can't afford this. Do you have any patient assistance programs? Because we can't actively promote that. So if you ask for it, we can help you. But if you don't ask for it, then we can't help you. So please, not even with Vyalev, but any type of medication, if you can't afford it, please call the pharmacy and say, I can't afford this. What can you do to help me? And then they will be able to get you in contact with our patient assistance programs. And most companies do have those programs.
Okay, thank you. And then I can only speak for myself, so maybe we have like 3 or 4 patients of ours at our clinic. Do you have any general numbers of how many pumps you have active, like in Pittsburgh within?
So I don't remember exactly but so for my area, I cover Northeast Ohio, Western Pennsylvania, and we're in West Virginia. And right in my area, I started my 51st patient this week. Okay. So I have about 51 people in my geography that I cover. So and across the country, I think we're up to a couple thousand. In the whole world, we have over 15,000 now patients using it.
Awesome. Okay. And then the last question is, like, start to finish, can you tell a patient, like, how would they have to go about getting this?
So if you want to get this, first talk to your movement disorder specialist. If they're not offering this, because some movement disorder specialists aren't offering this yet, ask them if they would be interested in offering it. If not, you can go onto our website. They have a doc find that has a list of all the doctors who are currently doctors, mid-levels, nurse practitioners, PAs that are using it. And then once the doctor sees that you qualify, they'll fill out a form. That form gets faxed into our hub, and then you'll get it reached out with a nurse ambassador. The nurse ambassadors are great because they come to your home. They train you about everything about the pump, how to install the cannulas, everything. So when you come back to your doctor, you're fully prepared and trained and understand, and they'll train your caregivers and everybody. So we want to make sure that we're with you all the way through those steps. And the nurse ambassadors, after you start the pump, will stick with you for 6 months after and provide additional training. And then when you come to the office, like say if you started with Dr. Cardone, I would be there in the office to help her set up the pump, calculate your dose, and do all that stuff too. So it's a relatively simple process, and we've started to get it, rolling. That on average, from the time you enroll to time you start is about 30 to 60 days.
Okay, and then another question that people frequently have is, can you remind us what are the sites that the cannula can be applied onto the body?
Yeah, so the cannula can be anywhere from armpit to armpit. So you have your whole abdominal area that you can put it on. You can put it on the back of your arm, and you can put it on your thighs. So there's multiple places where you can put it at. And that's where one of the things that the nurse ambassadors do is they help you decide what's the best place for you to put it. They help you the best carrying case. So that way, like I said, this is supposed to be something that's supposed to make your life easier and less cumbersome. It's not supposed to be making your life any harder. And most patients that start this are so happy they're on it, they'll do anything to stay on it. So
yeah, I agree. So like, again, what are the times where we would reach for this medication? Again, my cutoff is around 1,000 milligrams of oral levodopa is kind of where I start reaching for extra stuff. I'll reach for oral adjuncts. I've had a low threshold of going straight to these pumps because they're a good little minimally invasive but commitment free type of option. So you can try it. If you don't like it, you take it out and you're done with it. You can try it. If you have a little complications, we troubleshoot, try to work around it. But it's not like you're committing to any major like brain surgery. And if you try it, you don't like it, you want to try the other one, that's still an option. So it doesn't remove you or preclude you from being able to do anything else. So around, like I said, around the 1,000 milligram mark, and especially if I have patients who have a lot of GI issues, they're really having complications with constipation, and their gut is less reliable, and or people who have a hard time remembering to take the medication, either because their job or their life is just too busy. They're not always looking at the watch, trying to get a bottle of water, trying to get their pills. That's kind of like annoying. So this is a good option for people like that. Another good patient population for this is the patients who have a hard time getting up and moving around overnight, especially in the older age population, the population who has to go to the bathroom a couple of times a night. And when you get up and you're trying to walk around in the dark, that's just a higher risk of having a fall. And so this would be a good option there because it runs 24 hours. You still get dopamine throughout the night. And that itself should cut down some of the urinary frequency, or at least the portion of it that could be due to the Parkinson's disease, because Parkinson's disease, if you remember, causes bladder muscle spasm of the muscle that keeps the bladder closed. So that creates the sensation of wanting to go to the bathroom. So if you have dopamine treatment all night, that should reduce some of that, and maybe you sleep better, have better quality and length of sleep. That makes your days a little bit better. And again, if you have the pump and it's going, you can kind of like forget about it and go about your business and not always be tied down to like setting your alarm clock, checking the watch, checking when it's time to take meds, and having to take meds. So this medication, for the couple people that we've had, has replaced their oral dopamine. I think it's replaced, like if they take entacapone, the booster for oral dopamine, it's replaced that because you don't need it anymore because we're bypassing the whole gut. For patients who have extra symptoms like the dyskinesias, if they're on amantadine, I usually leave that on if it's treating a different symptom. But I don't remember off the top of my head, maybe one or two of my patients if they're still on amantadine or not. So yeah, it can replace a lot of medication, provide more even coverage throughout the day without having as many of the on and off or wearing off periods because you're getting the same thing all the time. Can you explain a little bit about the different rates, like the high, low, and the extra?
Yeah. So the base rate is meant to be for patients when they're just at home, sitting, watching TV, not doing a lot of activity. Their body is not requiring a lot of dopamine. Now, if they're going to Rock City Boxing or they're going to go walk around the grocery store or go walk their dog, they would put it onto high. And then at night, when they don't require as much dopamine, they would put it down to low. But at any time during that time, if they felt like they just need a little more, they had the ability to use the boost and boost it more. So that's what's nice about this, is that it really can be customized to what the patient needs to prevent those dyskinesias from developing from having too much medication. We're basically wanting them to stay in this sweet spot and stay steady and do what their body would do naturally with the dopamine, if that makes sense. And we have a really good video on our website that people can go to and look at, and all of our safety information is on our website too.
If you don't mind, could you put a link to that maybe like in the chat if people want to?
Sure.
And just to remind me, so it's base rate and then high and then low.
Mm-hmm.
And when you said the boost, that is, you were talking about the extra
Yep.
boost you can give yourself. Okay, not switching to high. Well, you could switch to high.
Yeah.
Okay, so yes, throughout the day, your doctor would set specific amount of extra doses you are allowed to give yourself, as well as the quantity that you would get with each of these extra doses. So if you feel that you need that boost, you would push that button, you would get an extra dose. So again, highly customizable, minute by minute, based on what you are doing and based on how your body is feeling, and skipping the stomach. So if you need a boost but you just ate a big meal, it doesn't matter. So you could still get your boost of energy and boost of Parkinson's disease symptom control.
Yep.
Okay, thank you. Is there anything
You're welcome.
you can think of that? I think those are the most common questions that I get from people.
Yeah, that's usually the most common questions that I get from patients. And, you know, it's not right for everybody, but the people that do try it, they do like it and they want to stay on it. So that's always a nice thing to see.
Same. The few that we have, they're on it, they're not coming off. So they're happy with how they have benefited. So thank you so much, Shelly. I really, really appreciate you helping and giving us that talk too. That's very helpful. So if you put the link in the chat, or if patients need any additional information, you can reach out to me or even probably Casey. That information will be there. All right. Thank you, Shelly.
Thank you.
Thank you, Shelly.
Thank you.
Okay. I'm not sure if Brianna's on yet.
I am. Hi.
Okay, so before Brianna starts, I'll remind everyone, Brianna is going to be talking about Onapgo. Onapgo is the apomorphine pump, so not dopamine, but dopamine receptor activating chemical. So it just goes and sits on the dopamine receptor, pretends to be dopamine, and you can have symptom control with this. So go ahead, Brianna.
Right. So I will just show you from beginning to end of how we do the device and how you can get it started. So this is just my fake little skin pad. The cannula and everything is the exact same as Vyalev. So Shelly showed you the little plastic that goes into the skin. That's the same thing that you'll be using here as well. So you would have everything prepped and ready to go. We take the little device, you put it right on your skin, and then that's how it gets administered under the skin. You then would take your vials, which are pre-filled.
Sorry.
Oh, no, you're fine.
Hold it up a little steady because I think you have your
Yeah.
so it.
Oh, yes. Can you see it now?
Um,
Here, let me try to get rid of this.
if you just hold it like right in that sweet spot so people can see.
Okay.
All right.
Perfect. So that's just how it would go under the skin. And so the vials of medication are pre-filled, ready to go. They don't have to be stored in the fridge, so they could be sat out for you. What you would do is you would take the tubing and twist it right onto here. We take the vial and you just push it in. And then here is the Onapgo device, small in size. It is the average size and weight of an average smartphone. But once that's pushed all the way in, you just push it on, snap, and you're ready to go. So this is the device. This is how would be with it all set up. Your medication is already set, ready to go. Patients wear it. They can fit it in their pockets. A lot of our brand ambassadors do waistbands or fanny packs, things like that. One thing we do give you is a pouch. So this can fit right into the pouch. Then we give you a waistband. It straps right around your waist comfortably, or a lanyard, whichever you prefer. But it does fit in your pocket. It can go in a fanny pack, however you're comfortable with. But once that's on, you would just snap this into the cannula on your skin and start the medication. And that is how you would start Onapgo for yourself.
Thank you. And then
You're welcome.
can we go through the same common questions?
Sure.
Insurance, is it covered? How do you get it?
Yeah, so the coverage is looking really good. It is covered under Medicare Part B. Commercially insured is covered, no problem at all either. Something that Shelly touched on that we also do, and that's why I wanted to piggyback off of her, is if you do have any financial needs for your copay, please, please, please let that be known. Companies absolutely will help you. So that is something that her company offers as long as ours. So definitely take advantage of that. But coverage is looking really nice for patients.
Okay, and then what are the timings? So this is the one where it's 16 hours per day. And can you tell us a little bit about the different rate options? Like how does that work for patients?
Yeah, so every patient's different. So this is a 16-hour waking day period that you wear it for. We do take it off at night. You want to change out the cannula every night as well. We focus heavily on skin health care. That's how we reduce infection risks and overall. So we do change it out 16 hours, and it's only worn for the waking day.
Next to the Jabra, speak 510.
Sorry.
Go to the Bluetooth.
No, that's okay. That's okay. I'm so sorry. What was the second part of the question?
16 hours per day, and then the
the dosing. Right. Okay. So what we do is we start at 1 milligram an hour. Supernus does offer a clinical nurse navigator who comes to your home, and that is where she will help you assist with the titrating and getting you to your optimized dose. So we start at 1 milligram an hour, and then within the next 7 days is when we figure out what your optimized dose will be. So everybody's different. The max dose is 6 milligrams an hour. Typically, we're seeing patients at 4 milligram an hour, but it really just depends on how your body takes it. We titrate by a 0.5 milligrams. So we do go nice, low and slow, just to make sure there's no problems. Your body reacts to it really well. And then once we get you to the optimized dose, then the nurse will let Dr. Cardone know what dosage we're at, and that's just where you would stay pretty consistently. We also give extra plus doses or the bolus doses. So if you do have trouble throughout your day where you feel like you need a little bit more of the medication, you can administer up to 3 of those. But you won't know that what dose you might need until we actually have you optimized. Some patients need it, some patients don't, but it's a nice option that we do have there.
Okay, and I think that was the same. I think I got through all the questions that people commonly have. Can you hear me a little bit better now, Casey?
Yes.
Yes.
Sorry, there's 2 mics that are connected. I'm never sure which one it is. Okay, so again, can you walk us through the start to finish? How does a patient go about getting this?
Sure. So that's obviously a conversation between you and your patient to see if it's right for them. Typically, if they are on their carbidopa levodopa 3-4 times a day and already on other adjunctive therapies, this would be a good option for them. Before they leave the office, ideally, we could just snag a signature on the prescription form, and that's all the patient would need to do on that end. So once that's sent in, we're looking at about a 45-day period from the prescription being sent in to when the medication's being sent to your home and we could start administering. However, once that prescription form's sent in, we're looking at about a 72-hour range where that clinical nurse navigator will reach out to you to set up a welcome call and pass along introductions, get comfortable with each other, and you'll have a couple visits before with that nurse before you even start the medication to really decide if this is something you want to move forward with or if it's just not right timing right now for that medication. But ultimately, it does give you that opportunity to make that decision yourself, and then to just be well educated on the medication and all things Parkinson's. That is the nice thing about having that nurse with you.
All right, thank you so much, Brianna. I appreciate it.
You're
Thanks for
welcome.
showing us all the equipment. People really like to see what does it really look like with a person holding it. So thank
Yes,
you for that.
of course.
All right, so basically to recap, we have 2 subcutaneous pumps that are available for treatment of Parkinson's disease symptoms. One of them is dopamine, and one of them is apomorphine, which acts like dopamine. So when do we start to reach for these medications? Me personally, around the 1,000 milligram mark of total levodopa per day, I start to look at any other options, including adjuncts or the subcutaneous pumps or deep brain stimulator surgery. The pumps are this nice little stepping stone. If you think maybe you want to go to the surgical route, but you're not quite ready to make that commitment, this is a good amount. This is a good non-commitment version that you can try. If you like it, great, you stay on it. Or for patients who are not quite at the DBS ready mark, meaning they haven't had their symptoms long enough, or they've got other medical issues, or they just are not looking at that right now, the pumps can be a good adjunctive treatment option. Right now, I personally don't have any rhyme or reason yet as to which one I choose. They're both quite new. I think maybe our kind of rule of thumb is like if a patient's doing well on carbidopa, levodopa. Can you hear a little bit better now or no?
Yes.
Okay, is this definitely better? Hello? Okay, I will
Yes.
hold this up here, sorry. Okay, so my kind of rule of thumb, I guess, is if a patient is doing well on oral carbidopa levodopa, but they're just having like a lot of wearing off and they're having a hard time with gut motility, and I want to just replace that with the subcutaneous carbidopa levodopa, I go for the Vyalev. And if they have a lot of issues overnight, I go for the Vyalev. If they're on a lot of carbidopa levodopa orally and we're pretty sure it's getting absorbed because they don't have constipation, but they just don't have good effect from it, then I go the other route and say, okay, let's just stimulate those dopamine receptors directly. And then I would choose the Onapgo. But again, that's a very loose kind of protocol. And we just, we have a very low threshold. If one doesn't work out for a patient, I have a low threshold of just trying and switching to the other. And I am keeping the option open for patients who already have DBS. If they still need something extra, the pumps can be an extra option. I would probably go for the Onapgo pump because it's, again, different than dopamine. Again, you can't really compare it. DBS is electrical stimulation of parts of the brain, and the Onapgo is stimulating the receptor on the other end. So again, no rhyme or reason there, but I would be open to trying both. So if you think that you might want to think that either of these might be a good option for you, you would start by talking to your movement disorders physician. Okay, that's all I've got for today. I can open it up to questions if anyone has questions.
Yes, thank you. And you can unmute yourself and ask one question at a time, or you can use the chat. Everyone's thinking away. That was very thorough. However, there might be a few questions. We'll just wait another moment.
Sorry, I have allergies today.
That's okay. Can anyone think of any questions? Oh, here we go. What is the threshold of levodopa that indicates switching or adding a pump?
So there's no official numerical number. My rule of thumb is around 1,000 milligrams of levodopa per day. That's when I have anecdotally noticed that adding more oral dopamine in any form is usually going to give somebody more side effect than benefit. So around 1,000 milligrams is when I start talking about extra stuff. Another indication would be if a patient has a lot of oral medications and they are still having a lot of wearing off, like after each dose they wear off after 3 hours and they have downtime for like a half an hour or 1 hour until their next dose, and it still takes a long time for that next dose to kick in, giving them a total off time in between of about an hour or more. That's the time where I start to think of adjuncts or skipping the stomach. How else can we get medicine more steadily into that patient without using the stomach? Another option is if I've had to increase carbidopa levodopa so much that the patient's getting dyskinesias, they're still getting the benefit we need, but also getting the dyskinesias, then I say, okay, let's try something else where we can get less potential side effect. If somebody is not really compliant about taking medications, this is an option, although you have to be careful with that because this also requires some maintenance too. So you have to change it and you have to use it. But if it's that they have such a busy day that they just don't have time to take medications but are cognitively intact enough to manipulate a little piece of equipment, then that might be a good option. People who have very erratic work schedules or sleep-wake cycles, so people who, again, not usually the age group we see, but there are some cases where they work night shifts and they're up during the day and it's just not a steady schedule every day, then the pumps are a good option there because you can just kind of like a crock pot, set it and forget it. Is that Crock-Pot brand who advertised as set it and forget it or something else from the 90s? But yeah, basically it's on and you don't really have to do anything and you don't really have to check the clock, and except for when it's time to like go to bed or turn it off. So those would be some of my thresholds for starting.
Thank you. Okay, how do you determine which pump medication to prescribe?
So there's no way right now. They're both so new. So again, I use some of the little differences between them. If I have a patient who has a lot of issues overnight, they're unable to get comfortable at night because they're so stiff, they have to get up to go to the bathroom, but they have such a hard time walking, then I have a lean towards the 24-hour pump, the Vyalev. If they are pretty active all day, but they're sleeping fine at night and they're doing well on the oral medications, like they're getting good effect from it, but just having wearing off, then I might go towards the Onapgo pump. That's it. There's no real good rhyme or reason yet because I don't have enough patients yet to really have a preference. Yeah, I guess like for patients who are taking dopamine and I think that they would benefit from the Onapgo because it acts on the dopamine receptors, I would probably choose that one. If they're just doing well on the regular dopamine, but I just want to skip their stomach, I would go for the Vyalev. Oh, the other perk of the Onapgo is that all of the adjustments are made in the patient's home. So if a patient has transportation issues or they live really far away and it would be easier for them to just get adjusted at their own house, that would be like one of the perks there rather than having to come into the office.
Thank you. Any other questions from the crowd? Okay, well, thank you, Shelley, Brianna, and Dr. Cardone. And there will certainly be more information about these two therapies in the future. And we will see you for the PD Parlor in September.
Yes, I don't have a topic yet, so if anybody has ideas they would like me to discuss, let Casey know.
Please let me know.
Thank you,
everyone.
Brianna, for helping me out today. Have a good day, everyone.
Thank you, everyone. Bye.